Welcome to the Visual Journal Club that is under the Journal of Physiology. My name is Dr. Edith Phalane. I'll be your host for this visual club. I am affiliated with the University of Johannesburg in South Africa. This will be the layout of the presentation. Once again, thank you very much for taking the time to be with us for this Visual Journal Club. This session will be divided into two sections. The first one, it will be the session seminar, which will go for about 45 minutes, and it will be divided into 4 sections, where I'll be the introduction that I'm gonna go into just now, and then it will be followed by the discussion of the article by one of the co-authors, and also it will be followed by also discussing what makes a winning article from editorial perspective, and also Q&A. Then immediately after this 45 session seminar, we will break out into 30 minutes networking session. We encourage that please join the networking session. We'll remind you towards the end of this session, and there will be a link that is posted in the chat function that you can join us so that we can reflect on this journal club and what we discussed. And we would also like to remind you that please, the session will be recorded, and the recording will be sent to you within a week's time after this meeting. And we'll also send along a feedback survey, which we would really appreciate if you could fill it out for us. And we also ask that please keep your mics muted throughout the discussion, but then you are allowed to mute and unmute yourself during the Q&A when you do the questions and answers. And also you are more than welcome to post your questions at any point during the session at a Q&A button that will be at the bottom of your screens. Just before we can just start with our session, I just want to give a brief view on how you can get involved in the Journal of Physiology, and also in the Visual Journal Club. You can do so by hosting a meeting like we are doing right now in the Journal of Physiology Visual Journal Club, or you can do so by writing an article as part of the Journal Club article, or also choosing to submit your research article with the Journal of Physiology, which covers original research papers in all areas of physiology and pathophysiology. For any further questions, please, you can do so by sending to the emails as listed below. Okay, so we are gathered here for the Visual Journal Club, and there's an article that I selected of interest that we're gonna discuss, and I'm just gonna go into reasons why this article was selected, which is titled Low Volume High Intensity Interval Training and in Cardiometabolic Health. We know physical activity is a key factor in terms of prevention and management of cardiovascular diseases, and high intensity interval training being another form of physical activities, which offers benefits in terms of cardiometabolic health management, and requires less commitment and lower energy expenditure. And I have chosen this article in terms of that is my area of focus. My research focuses on cardiometabolic health, cardiovascular disease management, especially in HIV-infected populations, and currently in my postdoc, including COVID-19. And what really attracted me also is that also looking in the COVID-19 pandemic, we know that mobility is quite limited. We are no longer doing things as we used to. Access to physical activity facilities is limited. So when I read on high intensity interval training, I looked at the benefits it offers, and in that you can do it at the comfort of your home, and also looking in the pandemic that we are limited to access in terms of accessing physical activity facilities and sport, what it could offer for people. And also looking at that cardiovascular disease alone right now, they are sitting as one of the leading causes of mortality and morbidity globally, and also in the context of COVID-19, they are associated with poor health outcome. So what better way to discuss physical activity, especially high intensity interval training, in terms of management of cardiometabolic health? So to do so, I am joined by two panelists, Dr. Angelo Sabag, who is part of the co-authors of this article. He's a postdoctoral research fellow at the Western Sydney University. And I'm also joined by Prof. Jeff Combs, who's the director at the Center for Research on Exercise, Physical Activity and Health at the University of Queensland. So without any further ado, I'm now gonna hand over to Dr. Angelo Sabag, who's gonna take us through and really give us an overview of this article, which I found very intriguing and educational also at the same time. Thank you, Dr. Angelo, over to you.
Thanks, Edith, for the warm introduction and for speaking so highly of the article we published. So I'll just share my screen with you guys and a little bit of background information on myself. I'm an exercise physiologist, and clinically I've focused on treating adults who have or are at risk of developing chronic metabolic diseases such as metabolic syndrome or diabetes. And so this led me to undertake a PhD at the University of Sydney, where I looked at novel forms of aerobic exercise to manage cardiometabolic health. And with one of them, emerging or one of the more topical interventions being high intensity interval training, it's only natural that I fell into this stream. So recently we published an article a review rather, in the Journal of Physiology that looked at high intensity interval training of low volumes for improving cardiometabolic health. And in order to understand, I guess, before we get started rather, I think it's important to define what it is that we mean by high intensity interval training. So in the study, we defined high intensity interval training as brief bouts of high intensity exercise, which is interspersed with active or passive rest periods. Now, most of you have probably been to your local gym and you've seen various classes being advertised as high intensity interval training. And although these classes are high intensity in nature, the literature typically refers to high intensity interval training as aerobic based exercise. So with gym based HIIT programs or group exercise programs, you do incorporate a lot of like resistance training, and it ends up being more akin to high intensity circuit style training. So it's important to define what it is that we're talking about here. And in the literature and in my presentation and the review that I published, we looked at aerobic based interventions. So that includes running, cycling, jogging, depending on your fitness, and even swimming. So there are many variations of high intensity interval training. These include low and high volume variation. So the difference between the low and high volume HIIT is basically just the cumulative interval durations, or rather the amount of time spent undertaking high intensity exercise. So for example, a typical low volume HIIT intervention, and I'll get into that a little bit further, could involve as little as 4 minutes of high intensity exercise interspersed with a warm up and a cool down period lasting around 5 minutes on each end. Now, as you're probably aware, that would total 4 minutes of high intensity exercise alone, and therefore we classify that as low volume. Classic high intensity interval training is like 4x4, and cumulatively that equals 16 minutes, so we classify that as high volume. Now, with regards to sit or sprint interval training, this is a little bit different because with sprint interval training, you're incorporating maximal all-out efforts. And because this requires a large anaerobic component or contribution, it's hard to sustain these efforts for greater than 30 seconds. So a very famous style of sprint interval training is perhaps Wingate training. And if anyone's done that, you know it's disgusting. After the third or fourth interval, you're struggling to even see. So the utility of this type of training, sprint interval training, is perhaps more questionable in a clinical setting. So for those reasons, this is why we kind of focused on high intensity interval training, which is typically classified or characterized by submaximal, in other words, below 100% VO2 max. So the first, I guess, the early studies that looked at high intensity interval training were published by Romo and by Ulrich Wisloff in the mid 2000s. Now they showed that this intervention here, which is 4 by 4 minutes of high intensity exercise, elicited similar and at times greater improvements in a variety of cardiovascular outcomes, and that these style of training was also effective and safe in clinical populations. So I guess these studies were kind of what sparked the interest in HIIT in the general public. And since then, there's been so many more studies published that have looked at HIIT for a variety of conditions, including mental health, cancer, HIV, and of course, obesity-related diseases. Now, one of the, I guess, key factors or reasons why high-intensity interval training is promoted so frequently is because it's touted as a time-efficient way to exercise. Now, I'm not sure about you, but if you were to ask me, 4 by 4 minutes interspersed with 4 minutes of recovery periods and warm up and cool down periods of 5 minutes or 4 minutes, whatever that is, that ends up equaling around 40 minutes of exercise, which isn't very time efficient. And as you know, lack of time is one of the most often cited barriers to exercise. Researchers have begun exploring novel and indeed true versions of time-efficient exercise interventions, such as low-volume HIIT. Now, there are two, I guess, typical interventions which involve low-volume, high-intensity interval training. Now, the first, which is promoted by and implemented by Martin Gabala and Johnathan Little, is 10 by 1. So they have 10 intervals of 1 minute. 10 by 1 minute intervals at around 80 to 100% VO2 max, and this is interspersed with 1 minute recovery. So it's a 1-to-1 ratio of work and rest. Now, with the other variation, which is a 1 by 4. Now, bear in mind, remember the previous slide we showed a 4 by 4. This is identical, except it has 75% less training time. So this kind of training intervention was implemented later on by Wisloff and Nathan Johnson and Professor Coombs, who's with us today, and he'll talk a little bit more about the study that he showed. And as you can see, the total training time for the above intervention is just over 20 minutes, and the below intervention is below 15 minutes. So this kind of shows that, okay, this might be indeed a time efficient way to exercise. But there are a few considerations that you need to keep in mind when interpreting these results. And we'll talk a little bit about that towards the end of the presentation. Now, these are some of the studies that have been published, and the study on the left, Professor Coombs will talk to a little bit later on. And the one on the right is the capstone project of my PhD studies, which was a randomized control trial. And we incorporated the 1 by 4 minute intervention, and we compared it to a moderate intensity continuous training intervention, which resembled the current physical activity guidelines, and as well as a placebo, which basically came to the center once every 2 weeks and did some light stretching and fitball exercises. And what we showed basically in this study, that is the one on the right, was that as little as 4 minutes of high intensity exercise 3 times a week for 12 weeks was comparable and at times superior to the moderate intensity continuous training intervention, which closely resembled the physical activity guidelines for improvements in cardiorespiratory fitness, in liver fat, which we know is crucial for glucose metabolism, and as well as glycemia. So, I mean, this was I guess, a precursor to the review that we published and set the groundwork for much of the work that we covered. Now, in addition to those studies that I've just mentioned, the remaining studies in the review highlighted that low volume HIIT can improve an array of cardiometabolic outcomes. So for example, with the heart, we know that it improves cardiorespiratory fitness as well as left ventricular function, decreases arterial stiffness and systolic blood pressure. We know that in terms of metabolic function, we have decreased insulin resistance in the peripheries, so in the skeletal muscle, as well as increased insulin sensitivity in the liver. We also see reductions in intrahepatic fat, which contribute to the subsequent reductions in gluconeogenesis, which is an endogenous production of glucose, as well as de novo lipogenesis. Now, these improvements, I don't want to overstate this, but they are contributed to by, at least in part, improvements in mitochondrial content and function, particularly oxidative capacity. So I'll talk a little bit to that in the next slide. So here we can see a model of skeletal muscle insulin resistance. And the green cycle, the green man on the bike basically indicates where low volume HIIT has been shown to, or which mechanisms low volume HIIT has been shown to improve. So in obesity, we see that we have high levels of circulating free fatty acids. Now, these free fatty acids eventually make their way into the cell and overwhelm the mitochondria's capacity to oxidize these. So what happens eventually is that, let me see if I can get a pointer. Yes, so you can see my arrow, my pointer now. So eventually, the accumulation of these free fatty acid byproducts, which can be diacylglycerol or ceramides, lead to the sustained activation of protein kinase C, which has eventually downstream effects that inhibit the translocation of GLUT4 to the membrane and contribute to elevated blood glucose. Now, what we've found is few things. Firstly, we found that, and this is work largely driven by Johnathan basically that mitochondrial function is significantly improved following low volume HIIT, and that these improvements occur at similar rates to higher volume exercise. And importantly, I'm not sure if you're aware, but the physical activity guidelines state that the physical activity guidelines for individuals with diabetes state that these people should exercise at least every 2 days. Now, the reason for this is, I guess, multifactorial, but one of them is that the primary driver of exercise-induced insulin sensitivity is glycogen depletion. And so, although the benefits that we're seeing on this slide are not unique to, I guess, high-intensity interval training, what we see is that high-intensity interval training has a unique, I guess, capacity to deplete glycogen in a time-efficient way. And so that's kind of where its benefits lies. You can exhaust your glycogen stores, which make the muscle more insulin sensitive and allow more glucose to be not only absorbed, but utilized, and then that contributes to the reduction in circulating blood glucose levels. So we could spend more time on this slide, but for the purposes of progressing, I'll leave it there. If you have any questions, feel free to ask on that, and we can go back and revisit it. And I think it's really important to also consider some practical considerations of these findings. And a lot of the times, especially within like news articles that have, I guess, spoken to some of our findings, we see that they overstate some of the improvements. So you need to consider the context for which these studies are undertaken. So the majority of them are undertaken in adults with obesity and metabolic abnormalities who, by definition, have exercise intolerance. And so that being said, it wouldn't take too much to see improvements. Now, if you were to get a healthy individual, would you see similar results? It's unlikely because you have healthy user bias. So finding who this kind of intervention is best useful for requires further investigation. But what we have shown recently is that low volume, high intensity interval training is comparable to moderate intensity continuous training for cardiorespiratory fitness, which is defined as, or being increasingly accepted rather, as a clinical vital sign. Another thing you need to consider is that the intervention lengths are around 12 weeks. So whether these individuals can sustain the improvement or continue to improve beyond these timeframes is currently largely unknown. And a practical consideration for clinicians wanting to implement this kind of training is that often these studies, although they don't inadvertently express it, incorporate some variation of progressive overload, whether it be by increasing the duration of the intervals, increasing the intensity of the intervals, or increasing total training time. Whatever it is, it's rare that the individuals start off exercising at the designated prescription. So there is like a ramp period where people and participants are allowed to acclimatize. So if you're wanting to implement this in practice, I'm sure if you're a skilled clinician, you know this as well, is give people some time to work into the ideal prescription that you are wanting to achieve. Now, another thing that we've seen, and this is specific to high intensity interval training, I'm not talking about sprint interval training, is that high intensity interval training appears to be safe and well tolerated. But you have to consider that most of the studies were supervised. So whether or not this safety is replicated in an unsupervised setting is, there is some preliminary evidence to suggest that yes, you can do it safely, particularly for individuals who have compromised cardiovascular health. But they still need to take caution, and if you're prescribing unsupervised exercise, make sure you equip your patient with the necessary skills to identify any red flags and to better monitor the intensity at which they're exercising. Now, finally, a really important point that not everybody enjoys exercise, and especially difficult exercise. Sometimes when undertaking high intensity interval training or CrossFit style training, during the intervention or during the training session, you feel like this sucks, this is terrible. And then you finish the session, you feel great. And then I think it's that feeling afterwards that keeps you going back in a lot of cases anyway. But some people don't have that response. And so you need to be considerate of the individual wants and needs when prescribing these kinds of interventions. Because for individuals who don't really like exercise, maybe HIIT isn't so useful, and maybe like a low to moderate volume continuous training intervention might be more applicable in the long run. So there's just a few practical considerations for you guys to consider. If you have any questions, feel free to ask. Otherwise, I'm going to pass it to Professor Coombs, who will talk about the editorial process and a little bit about his experience in the field.
Thanks, Angelo. In terms of the article, I guess you talked a little bit about mechanisms that are likely involved in the benefits that we get from low volume HIIT. I think in your article, you do talk about only a couple of the studies. So just reminding people that you presented in the article 11 studies that have used low volume HIIT. And out of those, unfortunately, only a few have really investigated the mechanisms that might be at play and might explain why such a low dose of exercise works. Could you just talk a little bit about those studies specifically?
Yeah, sure. One of the primary studies that we looked at was a recently published study by Ryan et al. So that was Johnathan Little's group, or he was a part of that study as well. And as mentioned, they basically found that the insulin sensitivity, the increased insulin sensitivity dissipates after 3 to 4 days following exercise, which is why that it's crucial to continue regular exercise. And they also showed that this, increase in insulin sensitivity was linked to glycogen depletion. So once the glycogen is restored, then the insulin sensitivity benefits largely dissipate because the skeletal muscle cell is no longer sending signals that it needs to be replenished as it's now fully fueled. So that's one of the primary mechanisms within the context of, diabetes and pre-diabetes. And there are other studies out of Japan that showed that highlighted some more cardiovascular improvements. So we showed that left ventricular filling and ejection fraction increased with low volume HIIT. Now, whether this is unique to low volume HIIT or superior to other forms of training is largely unknown. My suggestion is that it's not unique to this kind of training. Rather, it's just that you can achieve these benefits with a much smaller dose, which is why it's such an attractive intervention. Now, beyond the cardiovascular and the metabolic mechanisms, it's also important to consider the way that this kind of intervention can influence your likelihood to continue an exercise program. And there were studies by Mary Jung, who's a colleague of Johnathan Little's, who showed that after completing this kind of intervention, a high-intensity intervention or a moderate intensity, there were similar rates in physical activity 12 months after the intervention between both. And basically what I interpreted from that is that, as I said, high-intensity training isn't for everybody. And it's about finding what works for you and your schedule and your desire and your needs, I guess, and running with that. So I guess, I know I ventured off a little bit from your question, but I hope that kind of...
No, that's fine. I guess what I was highlighting and what became apparent in reviewing and going through the publication process of your article is the lack of mechanistic studies that have been conducted looking at just this question of how low can you go to get cardiometabolic benefits. And I really think it's a huge opportunity for researchers out there, both using basic science approaches and potentially human, more mechanistic studies to just see where thresholds might exist for things like intensity and duration of the dose. So I guess I just want to follow on with a little bit more of a practical question. And you did sort of allude to that with the comment around, well, potentially, depending, as an exercise physiologist, potentially you might be able to get the intensity up at the right straight away, and you've got to sort of play around with progressing, etc., etc. We do that a lot with our longer, higher volume HIIT sessions. So the 4x4s, for example, we can, spend the first 4-minute interval not focusing on trying to get their heart rate up. We usually use that 2 minutes as the threshold to try and get the heart rate in the target zone after 2 minutes. But you've got, if you don't get it up there in the first interval, you've got another 3 intervals to go. When they come in and they only do 1 interval, you really do need to have a really tight focus, I believe, on the intensity. And we've done a couple of these studies now. And I guess one of the surprising findings for us was people come in and they get a bit disappointed when they don't do as much exercise as they were. They go to a lot of trouble to come into the gym and to go through the warm up, and there's 1 interval and that's it. So we don't tend to do a lot of progressing. We have sedentary people with chronic disease that have been screened, really importantly, but we do try to get them straight up into that zone, first session, first interval, which is the only interval of the first session. Thoughts on that? Because I know this is from doing this a lot, these sort of presentations, it's a common question about how slowly you might need to progress someone.
Yeah, that's an excellent question. And I guess when we designed the intervention for our study, we considered that it's very difficult to get someone to their desired heart rate intensity when you have only 4 minutes and that's the only interval they have. So what we did was we did a work-based interval. So we calculated 90% the work rate equivalent to 90% VO2 max, so that when they'd come in, we put the wattage on the bike which they needed to, perform, and then they would do that for 4 minutes. Now, what we did find with that was that a lot of people, or not a lot of people, but there were a few participants who couldn't complete the 4-minute interval in one go. So what we did was that we would break it up into either 2-minute intervals with slight breaks until they finally could complete the 1x4. Now, that is, I guess, more applicable in a clinical setting when you have these kinds of facilities where you have electronically brake cycle ergometer that you can manually or automatically input the power output that you're desiring. But in a clinical practice, there was a few studies, high intensity studies by I think it's Kate Horsworth and Sophie Cassidy, where they used an RPE based prescription, and I love that because it is so translatable to the real world. Now, there are issues with RPE, namely that it's subjective and that my 18 might not be the same as your 18, particularly as we progress along the disease spectrum. And that the RPE scale was developed largely in healthy people. So there are questions about the validity of this kind of exercise intensity monitoring tool. But in terms of translatability, and ultimately, I feel like what we desire from our research is to be able to impact the lives of people living with or at risk of chronic diseases. And so if by getting them to exercise more regularly is our goal, then we shouldn't be creating unnecessary barriers that, so for example, we shouldn't be saying, okay, you need a heart rate monitor to make sure that you're exercising within this particular range to elicit benefits. And that's where I think using things like RPE might be beneficial in a practical setting. And of course, they need to be screened and they need to be run through the intervention by a properly trained exercise professional. Myself, I've been recently doing like N of 1 study where I'm looking at low volume HIIT and seeing how it can improve cardiorespiratory fitness. And I'm doing around 110%, 120% VO2 max for 1 minute intervals. And I'm slowly progressing the amount. So, I started on 4 and going up until 8. And although this is a higher, intensity, and not everybody can undertake 120% for a minute, I think that's, after doing that training, personally, I prefer the 10x1 model because it gives you more leeway than, say, just the 1x4. But that being said, I'm a young, relatively fit person. So whether or not this would be more preferred to by an older, conditioned person we don't know, and it's at this point individual. But the great thing is that there's evidence to support both of these interventions. And so its utility largely lies on the preferences and desires of the individual.
Agree. You talked about the monitoring the intensity with RPE, and we've looked at this quite a bit and published a guidelines paper. And if anyone's interested, Taylor's the first author on that in Progress in Cardiovascular Disease. And we talk about how when you get the initial prescription, and if you're lucky enough to get it from a maximal test, you get a heart rate max, and then you can prescribe the first session to that. But then what I think you need to do, and what we do really closely, is then what we call calibrate that to things like the heart rate response during the session and RPE, but not only the participant RPE, but also the observer RPE. So we use a combination of those three things in the first few sessions to try and calibrate that heart rate zone so it's, we believe, more accurate, more reflective of the target zone that we want. I think it's also important in using RPE that, especially with older individuals that might not have had much experience in self-perception of intensity, is really anchoring some of the numbers to previous experiences and spending a lot of time with participants on making sure they're aware and think they're doing a good job of monitoring RPE or assessing their own RPE. So, but I think it's really important because my concern is a lot of HIIT studies out there may not be using HIIT and may be using, or in terms of the overall dose, may not be over time, over the weeks, might be comparable with another study. And I think having spent quite a bit of time with the group from Norway that have done a lot of the work in the chronic disease and HIIT area, I certainly know their approach is much more about getting people into that zone every interval and making sure it's more towards the upper end of the zone. You know, they've looked at, then they've published on 89% of heart rate max versus 90 versus 91% from their collected data, and they show it is linear in terms of benefits that you get. So yeah, I just reiterating the importance of that, of putting the science into that getting the intensity right?
That raises such a good question, and I think it's really key to untangle this. It's like, okay, so you've mentioned that these benefits may be intensity dependent, but is the intensity more important than total volume? Because if you're working at a slightly lower intensity, you can perhaps accumulate more volume. And so then would the benefits be comparable, or would they be superior if you prioritize intensity over volume? And so that's kind of like, I guess, where we're at now with the literature, if I'm not mistaken.
Yeah, I think based on my experience in the studies that we've conducted, I'd always be prioritising intensity over duration. So I think getting the intensity up for as long as you can. But there's certainly a threshold where I think you can do the low volume to a point, and then when you start to get into the high volume, I think there's some questions coming in about whether there could be adverse physiological effects if you do too much, which, like anything, like anything, too much is also going to be detrimental to health. So understanding where that might lie, that other threshold might lie, is another whole question, which certainly aware there hasn't been a lot of work done on that.
Yeah, Edith, I know we have been running out of time.
Yes.
Can I ask I want to just raise one more point, because I think this is important for Professor Coombs to maybe elucidate for us, is in your experience, would you say that low volume HIIT in and of itself is a sustainable long-term intervention? Or do you think that even individuals with like obesity related disease need to eventually increase the amount of intervals or the intensity that they're doing?
Yeah, it's probably the most important question, as my dog starts barking again. I believe it's not sustainable by itself. I don't think you're going to get people, especially people with chronic disease, doing a HIIT session 3 times a week for the rest of their lives. I think what we've got to start to look at is how you can integrate HIIT into other moderate intensity activities, which are more likely to be completed and sustained over time. And yeah, again, a challenge for anyone out there looking to design a study that might have a combination of HIIT being, I think if you could supervise people forever and they come in 3 times a week and they're happy to, you probably could keep them doing HIIT for a long, long period of time, but that's not sustainable, it's not practical. So actually getting them to self-manage their own exercise, and we've seen in all our studies that, and similar with other groups too, is once they get out of that supervised environment, the HIIT people start doing less and less and less and less. And sometimes the moderate people start doing more high intensity as well, because they were in a study. They filled out a consent form that they said they were in a high intensity study. They got randomized to moderate and did moderate for 8 weeks, and now they want to try the HIIT. So we do get a lot of crossover once things are gone as well. That's more of a research setting. But I think sustainability is, we haven't seen it in our studies.
Yeah.
Okay, thank you very much, Dr. Angelo and Prof. Jeff, for the really insightful discussion. We have about 3 or 4 questions in the Q&A. I'm not sure if you are able to see the question, Dr. Angelo, or should I read them over?
I can see them, yeah. So do you want me to go through them?
The first question is from Dominic. He would like you to enlighten on glycogen depletion is helpful for better insulin sensitivity and glucose uptake. Should this be the case here as well? But no, he's first asking you, have you heard of post-marathon study? So
no.
they base...
Yeah, okay. So I'll try and answer this in, it's a very difficult question, because untangling the mechanistic effects of exercise in different contexts requires care. So we know that there's something called the athlete's paradox, which shows that individuals who have high VO2s, who are endurance trained, have large amounts of intramyocellular triglycerides. And we also see that this is the same for individuals who have diabetes and obesity. Now, obviously, something is differing between these 2 individuals in that one can utilize the fats way more effectively, and whereas The other being the individuals with diabetes and obesity cannot. Now, with regards to a specific question here, I'm not sure as to how to answer that best. But what I can say is that you need to consider that individuals with obesity and diabetes often suffer from aerobic impairments, which means that they are shifting to glucose reliance at much lower intensities than individuals with who don't have these metabolic abnormalities. So that might be one of the key factors that makes a difference between the response post-exercise between these cohorts. But you need to be careful when analyzing. You need to be specific with the context at which you're looking at. You cross-comparing. I know that our ideal model of health is in the athlete, and then we go from there and try and see how that is implicated in an obesity or a disease state. But you need to yeah, I just want to just caution people when doing so, and that you need to be very careful when extrapolating those kinds of findings.
Okay, thank you so much. He also has another question on whether do you think there's a limit of only one HIIT session, which could lead to too much metabolic stress and result as well as in worse glucose uptake?
Do you think there is a limit of only one HIIT session? See, this is again going back to the original study, and you need to look at the context. And we see that in my review looked at largely obesity-related disease, so cardiovascular disease and obesity and diabetes. And basically, in this cohort, it's well-characterized cohort in that we can predict with a fairly accurate I guess models what their response to exercise will be with glucose curves, glucose and insulin curves. So again, I think that the goal of, and this is reflected in the position statements, the goal for exercise in diabetes is to undertake regular exercise. The reason for this is because you can increase the duration of insulin sensitizing effects for the muscle. So if you exercise 3 times a week, we know that the insulin sensitivity is increased for up to 48 hours, sometimes 72. That means that you're prolonging the state of insulin sensitivity throughout the week, and that will lead to better health outcomes and prevent many of the diabetic-related complications, such as macro and microvascular disease.
Okay, you also have another question from Israel, but I don't think if we will be able to take all the questions because we are approaching the time to be finishing with this session, but we can continue with the questions and further discussion to reflect on this discussion in the networking session, of which the link is going to be sent to you just now in the chat box, where you can join for the networking sessions, and any further questions that you have, you can interact with Dr. Angelo and also Prof. Jeff and myself, and also us as the panelists, to really just reflect on the discussion that we just had. So at this time, I really just want to thank everybody that have taken the time to participate in this visual journal lab. It would not have been possible without you as the panelists. So we thank you and we appreciate you for that. And before I close off, I also want to just make a quick announcement that next week, Wednesday, there will be another visual journal lab that will be hosted by the Journal of Physiology, of course. It will be on Wednesday at 1200 BST. The topic will focus on genetic and epigenetic regulation of skeletal muscles, ribosomes, biogenesis with exercise. So we do invite you that please next week do join again the Journal Visual Club. But again, once again, before we exit, please do click on the link to join us for the networking session so that we can discuss some of the questions that we did not have the time to get into. And once again, Dr. Angelo, Prof. Jeff, thank you so very much for honoring the invitation to be part of the panelists and to discuss on HIIT and cardiometabolic health. I really appreciate it. Thank you so much, our attendees, and I'm looking forward to see you in the networking session. Thank you.